Walter is 78 years old. Chest pain on a Tuesday morning sends him to the emergency room, and 4 days later he's still in a hospital bed, hooked to a monitor, getting the same nursing care, the same tests, as the man in the room next door. Walter assumes, like almost everyone does, that 4 nights in a hospital bed means he's been admitted. He's wrong, and he won't find out how wrong until the bill shows up. That's trap number one. There are 7 more just like it. Not because anyone is necessarily trying to take advantage of you, but because almost none of these rules get explained out loud at the bedside. So, today I'm going to walk you through 8 of the biggest hospital traps that seniors fall into in this country. How you get billed, what gets changed without telling you, how you get pushed out the door before you're actually ready, and what you can unknowingly sign away in the first 15 minutes, and exactly what to say, in the moment, to protect yourself or someone you love. Stay with me through all 8 because some of these build on each other, and missing one early on can quietly cost you tens of thousands of dollars later. Grab a notepad. Let's get into it. Trap number 1. The observation status. Let's go back to Walter. The reason he wasn't admitted has a name, the 2 midnight rule. Since 2013, Medicare has used this as the standard for whether a hospital stay gets billed as inpatient or as outpatient observation. It has nothing to do with how sick the patient looks or how many nights they actually spend in the bed. It asks one narrow question. Does the doctor expect, at the moment they're making the call, that the medically necessary care will span at least 2 midnights? Expect less than that, and the default is observation, even if the patient never leaves the room and receives identical nursing care to the person admitted in the next room. And 2026 has made this more likely, not less. CMS just finalized a phase-out of what used to be a protective list of surgeries that automatically guaranteed inpatient status. Over 280 procedures, mostly orthopedic and spine surgeries, came off that list this year. On top of that, hospitals are now facing new quality rating pressure, where formally admitted patients count toward a hospital's public complication statistics, and observation patients generally don't. So when a borderline case is kept in observation, they don't just save money, it keeps a possible complication off the hospital's public scorecard. And here's why this matters in dollars. If you're formally admitted as inpatient, you owe one Part A deductible, $1,736 in 2026, and that covers your first 60 days with no daily coinsurance. If you're in observation, you're billed under Part B instead, a $283 deductible, then 20% coinsurance on every single service, every test, every scan, every medication, billed separately. Because observation stays generate so many individual line items, the total can rival or exceed what the inpatient deductible would have cost. And on top of that, your own home medications might not be covered the way you'd expect, which we'll come back to. So, what to do in this situation? Ask the following question every single day of the stay because status can change without you being told. Am I currently classified as inpatient or am I under observation? If the answer is observation, follow up with, what specific clinical criteria would need to be met for inpatient admission? And ask to speak with the hospital's utilization review department. And if your status gets changed mid-stay, insist on getting a copy of that notice. Your appeal rights and your paper trail both depend on it. Trap number 2, the skilled nursing coverage trap. This one is the direct, expensive consequence of trap number 1, and it's the one that blindsides families the hardest, because it often doesn't show up until you're already trying to leave the hospital. Since 1965, Medicare has required you to spend at least 3 consecutive days as a formally admitted inpatient, not observation, not ER time, actual admitted inpatient days, before Medicare Part A will pay for a follow-up stay in a skilled nursing facility. This is called the 3-day rule. And here's the brutal math. If you spend 1 day admitted and 2 days in observation, that's 3 total days in the hospital, but only 1 counts toward this rule, which means 0 protection for your rehab stay. If you do meet that 3-day threshold, Medicare Part A covers your first 20 days of skilled nursing care completely, then a daily copay of $217 for days 21 through 100 in 2026. But if you don't meet it, you're paying the full private pay rate, and the average cost of a shared room in a skilled nursing facility runs around $300 a day. A 20-day stay that would have cost you nothing under a qualifying inpatient stay can run upward of $6,000 out of pocket instead. Now, there is a narrow bit of good news here. As of 2025, more than half of traditional Medicare beneficiaries are aligned with something called an accountable care organization, or are on certain Medicare Advantage plans, and both of those can waive this 3-day rule entirely. Altogether, more than 70% of Medicare beneficiaries now have some form of coverage that can waive it. The remainder, in unaligned traditional Medicare, remain fully exposed. So, in this scenario, before agreeing to any skilled nursing placement, ask the discharge planner directly. Did I have 3 consecutive inpatient days, and will that be reflected on the claim? If the answer is no or unclear, ask whether they're in an ACO or a Medicare Advantage plan that waives the requirement, and get the answer in writing before you sign anything. Trap number 3, but it was in-network surprise bill. This is the one that makes people feel like they did everything right and still got burned. The No Surprises Act, in effect since January 2022, was built to stop exactly this. A patient goes to an in-network hospital, but gets treated by an out-of-network anesthesiologist, radiologist, or pathologist they never chose and never met, and then gets billed the difference. Under the law, those ancillary providers cannot charge you more than your in-network cost sharing, and for genuine emergencies, that protection is even stronger. But there are real gaps, and 2026 has surfaced some new ones. Ground ambulance transport is excluded from the federal law entirely. Only air ambulance is covered. And while 22 states have passed their own protections, those don't reach self-funded employer plans, which cover a huge share of American retirees. Then there's something called tiered networks. A provider can be technically in-network, but quietly moved into a higher cost tier with a substantially bigger copay. Medicare Advantage data shows this now flags nearly a quarter of all zero-deductible plans. And that premium tier almost never shows up when you are casually scrolling an online provider directory. And then there are ghost networks, provider directories listing specialists who've retired, relocated, or never actually accepted the plan in the first place. This has become enough of a problem that a wave of class action lawsuits is underway, including one case alleging an insurer's directory listed a single psychiatrist 29 separate times just to inflate the apparent size of their network. And the one that should genuinely alarm you: Medicare Advantage insurers can retroactively decide that an ER visit didn't actually meet the definition of an emergency after the fact, turning what felt like an emergency into an out-of-network bill. One documented case involved a man on a Medicare Advantage HMO who had a cardiac episode while traveling, was stabilized in an in-network ER, and was later told his continued hospital stay was non-emergency and out-of-network. The bill? $20,000. So, in this situation, before any scheduled non-emergency visit, confirm network status separately for the hospital, the surgeon, the anesthesiology group, and any imaging provider. They're often separate contracts. Request a written good faith estimate. It's your legal right. If a bill arrives that should have been protected, contact the No Surprises help desk. And if it's a ghost network problem on a Medicare Advantage plan, file an expedited grievance citing network inadequacy and demand authorization for out-of-network care at in-network rates. Trap number 4, the medication switch. This trap is sneaky and is just the result of bad communication. Nearly every hospital, 92% of them, operates on a closed formulary, meaning a specific list of medications their pharmacy stocks and has approved. When you're admitted on a home medication that isn't on that list, the hospital pharmacy performs what's called therapeutic interchange, swapping in a different drug from the same class that they do stock. One study of 100 admitted patients with a median age of 71 found that only 18.5% of their home medications were already on the hospital formulary. 44% got switched to something else within the formulary. Here is why this matters so much for older adults specifically. Geriatric patients have more sensitive systems, different drug clearance rates, and more complex interactions. The same research found that patients who underwent a therapeutic substitution had a discharge medication error rate of 11.5%, compared to just 4.2% for patients whose home medications weren't touched, nearly 3 times the risk. Medication-related issues caused by this kind of miscommunication cost the U.S. health system an estimated $100 billion a year, and nationally, 1 in 5 hospitalizations is complicated by a post-discharge adverse event, 2/3 of which are medication-related. So whenever you are admitted, bring a complete written list of every medication, dose, and frequency, including over-the-counter drugs and supplements. And don't assume the hospital's electronic record matches your pharmacy's correctly. Ask early. Has anything on my home medication list been substituted, and why? And at discharge, request an actual conversation with a pharmacist or nurse, not just a printed sheet, and ask specifically what changed, what stopped, and what's genuinely new. Trap number 5, the premature discharge. This is what's sometimes called rehab dumping, being sent home, or to whatever facility has an open bed, before you're actually ready, often because of financial pressure on the hospital's end, rather than your medical readiness. Within 2 days of being formally admitted, every hospital is required to give you a signed notice called an important message from Medicare, explaining your right to appeal a discharge decision. If your stay runs 3 days or longer, you get a second copy of that same notice again, close to your actual discharge date. Here's the part that matters most. If you believe a discharge is happening too soon, you have to contact the review organization listed on that notice, called the BFCC-QIO, before you actually leave the building on the day of discharge. File on time, and you cannot be discharged and cannot be billed for the contested days while it's under review. The hospital then has to explain its clinical reasoning in writing, and a decision typically comes back within about a day. Miss that same-day window, and you still technically have appeal rights, but you lose the protection of staying covered while it's reviewed. This isn't a hypothetical concern. Elder law attorneys and patient researchers describe real financial tension behind discharge timing. Some hospital discharge planning is oriented more toward cost control than patient readiness. Patient safety research on older adults' own accounts of going home consistently surfaces the same theme: an insecure and unsafe transition, with people describing real anxiety about what they do without help once they walked out the door. Therefore, you must read that important message from Medicare the moment you get it, not when discharge is already imminent. If discharge feels premature, do not sign anything under pressure. Say clearly, I want to file an expedited appeal with the BFCC-QIO before I am discharged, and ask for that phone number from the notice. And request a discharge planning meeting early in the stay, before a date is even set, because intervening early is always easier than reversing a decision that's already been made. Trap number 6, the signature trap. One of the most consequential things you can sign at intake, often without realizing it, is a binding arbitration agreement, which is often buried inside general consent forms. A binding arbitration agreement signed at intake generally hands future disputes over your care to a private arbitrator rather than a courtroom. That decision is typically final, with no real appeal path, and arbitration fees can run into the thousands. Here's the important legal fact. Hospitals are barred from making emergency treatment contingent on signing one of these. For nursing homes and long-term care facilities specifically, federal protection is even stronger. A 2019 CMS rule prohibits requiring a binding arbitration agreement as a condition of admission at all, and gives you a 30-day window to rescind it even after signing. There's also financial responsibility language to watch for, sometimes called responsible party clauses. For nursing homes, federal rules explicitly prohibit requiring a family member to personally guarantee payment as a condition of admission. A family member can volunteer to do this, but it cannot legally be required, and that distinction is rarely made clear in the paperwork itself. And separately, if you're uninsured or paying out of pocket, you have a specific right under the No Surprises Act to a written good faith estimate before non-emergency services, and the right to dispute a final bill that comes in $400 or more above that estimate. So, before signing anything beyond the basic consent to treat, ask directly, is this document required for my care, or is it optional? Arbitration agreements and many guarantor forms are legally optional, even when handed to you alongside required paperwork. If you're acting as someone's representative, ask point blank whether you're being asked to personally guarantee payment, and get copies of everything you sign before you leave the admissions desk. Trap number 7, the silent harm. This one doesn't come from paperwork or billing codes. It comes from simply being in a hospital bed. Hospital-acquired infections affect roughly 648,000 patients a year, generating about 721,800 infections in a single surveyed year. Pneumonia and surgical site infections each account for around 22% of cases, with C. difficile the single most common pathogen involved. Research suggests up to 65% of urinary catheters placed in emergency departments may be clinically unnecessary, and the longer one stays in, the higher the infection risk climbs. Falls are just as serious. Somewhere between 700,000 and a million hospitalized patients fall every year in this country, and that rate climbs to 8 to 13 falls per 1,000 patient days, specifically in units that care for older, more medically complex patients. More than 80% of falls go unwitnessed by staff, and underreporting is so common that researchers believe incident reporting systems may miss as much as half of all actual falls. But the harm that gets talked about the least is deconditioning, and this is the one I most want you to hear. Measurable physical decline can begin in as little as 20 to 48 hours of bed rest. One study found that 67% of older patients showed no improvement in function between hospital day 2 and their actual discharge, and 10% showed further decline. Delirium, the acute confusion that often comes with this, roughly doubles the risk of death during that admission, and is linked to an 8-fold increased risk of a later dementia diagnosis. For years, hospital culture leaned toward keeping older patients in bed to prevent falls, and that overcorrection actually accelerated the deconditioning that makes falls, delirium, and infection all more likely in the first place. Current best practice has flipped. Early, supervised movement is now the protective strategy. So always make sure that you ask the staff member entering the room whether they've washed or sanitized their hands. Ask daily whether any catheter or IV line still in place is actually still necessary. Ask whether a fall risk assessment has been done, and request a physical therapy consult early, not the day before discharge. And ask about the mobility plan directly. How many times a day will the patient be helped to sit up, stand, or walk? Report any new confusion or unusual sleepiness immediately. Don't assume it's just being in the hospital. Trap number 8, going in alone, the one that makes all the others possible. This is the last one, and I've saved it for the end on purpose, because it's the one that determines whether you can actually use everything we just talked about. A patient who is sedated, in pain, or simply exhausted from 4 nights under monitoring is in no position to track their admission status, identify a medication switch, or file a same-day appeal while still in the building. Federal rules quietly acknowledge this. When a patient lacks the capacity to act for themselves and has no representative on file, hospitals are permitted to transfer those rights to whichever family member happens to be present, not the most informed one, whoever is there. There's an important distinction worth knowing here. A family member who happens to be present is not the same as a formally designated healthcare proxy. In one Massachusetts court case, a son's authority as healthcare proxy was found insufficient to bind his mother to an arbitration agreement, because a proxy focused on medical decisions doesn't automatically extend to financial or legal documents. Setting this up before a crisis hospitalization, not scrambling to figure it out during one, is what gives someone real legal standing to act. The advocate's job during a stay is simple, even though it covers a lot. Be present or reachable for physician rounds, since that's the fastest way to get a direct answer instead of a second-hand update. Track the medication list from trap number 4. Ask the daily status question from trap number 1. Request the early discharge meeting from trap number 5. Those 3 actions alone address most of what we just covered. And if there's no family member who can take this on, professional geriatric care managers exist specifically to fill this role for people without family nearby. So consider establishing a healthcare proxy or durable power of attorney before it's needed, not during a crisis. Keep a copy accessible, including digitally, and bring it to every admission. And whoever takes on this role should plan to actually be there, because every single trap on this list is easier to avoid with someone standing beside the bed asking questions out loud. None of these 8 traps require a hospital to act in bad faith. The rules are public. The forms are legal. The incentives on both sides are real. What every single one of them shares is a quiet assumption that the patient, or someone beside them, will ask the right question, on the right day, before a deadline that was never announced out loud finally closes. That is genuinely the whole game here. If you want personalized help working through any of this, a specific bill, a specific discharge, a specific notice you don't understand, there is a free resource in every state called SHIP, the State Health Insurance Assistance Program. These are trained counselors, no commissions, no sales pitch. Find your local SHIP at shiphelp.org or call 1-800-Medicare. For Medicaid or elder law planning connected to any of these traps, search for an accredited elder law attorney in your state through the National Elder Law Foundation at nelf.org. If you have a parent, a sibling, or anyone who has a hospital stay coming up, please share this video with them now, not later. Because the time to know these rules is before you walk in, not after the forms are already signed. Take care, and I'll see you in the next one.